I'm Frank Chalet with the Parkinson's Resource Center of Spokane, and I'd just like to welcome certainly our folks here in the Spokane at St. Luke's, as well as all our remote sites. Thank you for joining us today. And on behalf of Northwest Parkinson's out of Seattle, our friends over there, and certainly the Parkinson's Resource Center of Spokane, I'd like to thank everybody again for all of your support and certainly your attendance and your interest in helping us bring this program to you each and every month. We already talked about our new staff member, and so what I'd like to do, as is customary, is certainly thank our sponsors, because as we all know, those of you who have been here many times, these things don't happen without support of local businesses, et cetera. So I'd like to thank our friends at St. Luke's here, Albertsons, also Northwest Parkinson's for their support, and the Parkinson's Resource Center Board of Directors, who put in a lot of time and energy in making things happen. And I'd also like to thank each and every one of our sites, and for you guys spreading the word out there to have more and more people that are attending these programs every month. And so it's exciting to see more voices and faces out there that are benefiting from each one of these educational programs. And lastly, these things certainly don't happen without all of our volunteers, so I'd like to thank Walt Jacobowski and Jackie Ewell and all our friends out front who are helping to check people in for their time each and every month. As is protocol, I'd ask everybody in the remote sites as well as here in Spokane to hold your questions until the end, and then I'd ask you then to turn on your mics at the remote sites so we can get into the Q&A session. So without further ado, I'd like to introduce today's special speaker. Dr. Suzie Rowe is a neurologist who specializes in movement disorders with a focus on the diagnosis and treatment of Parkinson's disease as well as other disorders. She has done quite a bit of training in many different cities in Canada as well as at Yale, in Boston, and so she's obviously very qualified. Today's topic that Dr. Rowe is going to speak on is sleep and fatigue. So without further ado, Dr. Suzie Rowe.
Hello. Can everyone hear me? Should have worn taller heels. All right. So I'm Suzie Rowe, and I'm very happy to be here with all of you. Thank you for having me. And forgive me if some of you may have heard this talk before. Sleep is one of my favorite topics because it affects 90% of people with Parkinson's and 100% of people in general. So I have given this talk before, but I think it's a good review because it does impact pretty much every aspect of Parkinson's. I'm going to start by talking about what exactly is sleep and why is it so important to all of us, and review some of the common problems that can happen with sleep and how to manage them. So what is sleep? I have a definition here on the slide. Basically, that's French for it's not just a period of nothingness. You think that just because the eyes are closed that nobody's home. But actually, during sleep, it's one of the most important times when your brain recovers from the day before and prepares for the next day. I kind of think it's like the Walmart overnight shift, where if the floors weren't cleaned and the shelves not restocked, then the business would not happen well the next day. So sleep is actually a very active phase during the day when a lot of things happen in the brain that's important. I'll talk about what some of them are. Before that, I'm going to just introduce to you how sleep is described in medicine. There's two main stages. There's rapid eye movement sleep, that's REM sleep, and they call it that because the eyes are rapidly jiggling around and the rest of the body should not be moving. It's the stage of sleep when people dream and the brain waves are extremely active on an EEG, and I'll show you what that looks like. So even though the body's not moving, the brain is actively working. And during this stage, the eyes are moving, the body's not moving, but there are autonomic fluctuations. That means the heart rate is up and down and the temperature is up and down. And we think that this stage of sleep is important in memory consolidation. So you can imagine if it were not going well, that there may be problems with the memory. The other part of the sleep is known as non-REM sleep, and there's four main stages of that. You start awake and then you get into a light drowsy. That's kind of where we'll all be in about 5 minutes if you've just had lunch. And then if you don't interrupt that, you fall into a more intermediate level of sleep, which is half the stage. And then you fall into a deep sleep, and that is the stage that's the hardest to get. This is when the brain recovers and you get your alertness restored for the next day. So sleep occurs in recurring cycles lasting about an hour and a half to 2 hours, and the cycle repeats itself multiple times a night. But there are changes in sleep as we age. People have less of that deep, refreshing sleep and wake up more frequently between the stages and even during. Most adults need about 7 to 8 hours of sleep, but the older we get, people's sleep is fragmented. So you might sleep only 6 hours a night and wake up and then need a nap later in the day. And even though there's fewer hours of sleep, you need more sleep to get that quality or deep sleep that gives you the rest. And Parkinson patients even average less sleep than that and wake up twice as often. Now, this is a picture of the sleep architecture from a sleep study, and I'll show you a picture of that. And basically, as we talked about, you start out awake, you get into light and then deep non-REM sleep, and then you have a little bit of REM sleep early, and then you cycle through those 4 stages again. And you can see that the REM part of the sleep is more in the second half of the night, and so you need to be asleep a certain number of hours to get that. And so are the deeper stages of sleep. Now, the older we get, the sleep gets very fragmented. There are many more times when a person's awake. There's less time in the deep stages of sleep, and the REM sleep is more fragmented and earlier on in the night. So why is sleep important? We think that this is when the tissues repair in the body and the brain. This is when the brain makes energy for itself. In the developing brain in young people, that's under the age of 21, the brain is still developing and growing, and this is when memories that are made every day are consolidated. You need the rest. And in Parkinson's specifically, there's something called sleep benefit. And what that means is, many of you can probably tell me better, but when you wake up from a good, refreshing sleep or nap, it's like the meds are working even better, or even better than the medicines. The tremor is less, the stiffness is less, the walking is easier, and that's because the sleep itself helps the symptoms of Parkinson's. So conversely, if you don't get enough sleep, there's a lot of bad stuff that can happen. The memory's not consolidated, you can have trouble concentrating, trouble learning new things, and slowed reaction time. The slowed reaction time that's already a problem can get worse. People make poor decisions and perform inconsistently on tests. The mood gets irritable. You have no energy. You feel restless and grumpy. And I always tell people, just to put things in perspective, if you drive a car while sleep deprived, it's actually worse than being drunk behind the wheel when you've compared the reaction times and judgments of people who are severely sleep deprived versus alcoholics. That's how severely impaired it can be. There are also medical changes. So chronic sleep deprivation can increase the risk of heart disease, obesity, infections, and impaired immune dysfunction and headaches. And it's amazing to me when people get treated for their sleep apnea, for example, how many of these symptoms get better. The other thing I always ask people at least once during a visit, so how are you sleeping and are you drowsy during the day? And half of the people who will tell me, I sleep like a rock, there's nothing wrong with my sleep. Half those people have a sleep problem, and in fact, probably 2/3 to 90% of Parkinson patients have had some sleep problem during the course of their Parkinson's. And this is important because even if you think you're sleeping well, if you're excessively drowsy and having trouble staying awake, that is a sign in itself that there's something wrong with the sleep. And those people can have an undiagnosed sleep problem that can be potentially fixed. So I'm a big fan of sending people to the sleep clinic and diagnosing what that problem is. And most of the time you find something that can improve with treatment. In fact, when I moved here, I got a personal call from 3 of our local sleep doctors thanking me for sending everybody to the sleep clinic. But I'll tell you, 95% of the people I have sent came back with something that we needed to fix. So it was very high yield consultation. So this is a Epworth Sleepiness Scale. This is a questionnaire that we sometimes use to try to find out how sleepy someone is. And if you give yourself a number for each one of these activities, how likely are you to doze off when sitting and reading quietly or watching a TV show? Give yourself a number for all of these things, and if you add them up and it's greater than 10, you're too sleepy. And if you're greater than 18, you're severely sleepy, and we should have it looked at by a sleep doctor. So this is a copy of the sleep study that I've mentioned to you. PSG stands for polysomnogram. And basically, it's a way to measure all the different aspects of sleep and kind of diagnose where the problem is. It has a lot of different components. One is called the EEG, or an electroencephalogram, and it's basically they put a bunch of stickers on your scalp, and it can record your brain waves through your scalp and tell what stage of sleep you're in. You can measure someone's respirations, how their chest is moving up and down, how their oxygen and carbon dioxide levels are, how much body fidgeting is going on. Maybe there's severe restless legs, or maybe they should be in REM sleep, but they're having a nightmare, and I'll talk about what that means. They can diagnose irregular heartbeats, and are there arrhythmias? And so all kinds of different things can be discovered on the sleep study. So that's just a little introduction to sleep, and I'll talk now about what can go wrong with sleep and how we can hopefully fix some of them. Insomnia just means problem with sleep or lack of sleep. And we look at it as acute or chronic. That means it was sudden and just happened recently, or it's been going on a long, long time. It can happen when you're trying to fall asleep or at sleep onset, or it can cause you to wake up during the night, sleep maintenance. It can be just on its own due to no apparent reason, or due to something else, a medical condition, medications, or other problems. And there are a number of very specific sleep disorders, which I'll discuss. The most important thing to walk away with today is the sleep, other than sleep disorders are common and underdiagnosed, is that sleep hygiene can really help you. Hygiene just refers to personal habits. And basically, if you pay attention to your sleep and be good, as it were, you can sleep a whole lot better just from changing your behavior. So it helps to fix a regular bedtime or waking time. You know, you don't have to be terribly strict about it, but if you know that you're sometimes staying up till 3 and 4 in the morning, if you tell yourself, I'm going to bed at 10 or 11 and turn out the lights and make it your business to go to sleep at that time, that'll work a whole lot better than just going to sleep whenever, because a lot of us lose track of time and can stay up way too late. So fixing a semi-regular schedule is very helpful. Avoiding naps. Now, naps are not bad. I think naps are very good. I wish I could have a nap every day myself. But if you nap for 3 hours, 2 or 3 times a day, you're sleeping the entire day away. And then when it comes to bedtime, well, you're awake because you slept the whole day away. So it's okay to have a brief nap. It can be a great refresher in the middle of the afternoon. But if you find yourself napping because, well, there's nothing else to do, you've got to find something to do, because you should be active in the day and resting at night. So this is all the list of things that you like but are bad for you: the alcohol, caffeine, nicotine, heavy, sugary, spicy food. Again, it's all in moderation and in schedule. You can have those things. Well, I don't urge any of you to smoke, even though nicotine has been inversely correlated with Parkinson's. If you're going to have these things, try to have them not within a few hours of bedtime and only in small amounts. Exercise, I think, is great for everything. But if you exercise vigorously and it's 10 p.m., it's going to be hard to wind down and get to sleep. So try to do it not too close to your bedtime. And reserve bed for sleep and basically just sleep. I'm hearing voices. But basically, don't bring your work in there. Okay, a little reading is very nice, but you don't want to spend 6 hours in bed doing work and reading and watching TV. Preferably, if you could do that in the next room, and when it comes time to bed, turn out the lights and just get in bed and sleep. Now, if you're in bed tossing and turning for hours and hours, it's probably not going to work. So I suggest people get up out of bed and do something relaxing, and that could be anything. It could be, you know, reading something, listening to music, some stretching, warm bath, meditation, whatever it is that you do. Try that, and then go back and lie down and try again. I've been reminded very recently that having a firm mattress and silky sheets can be helpful for people who have trouble rolling over in bed. And so having a comfortable bed that's not too warm, something that's easy to roll over, and that can be very helpful as well. These are a short list of some medical things that can interfere with sleep, and I'll usually ask a few questions related to this. You know, some people can't sleep because every time they lie down, they get short of breath, or they have burning heartburn. They got a lot of muscular aches and pains. They have to get up 6 times a night to urinate. If that's the case, a medication to calm overactive bladder or not drinking liquids after dinner can help. Nocturnal akinesia means stiffness, can't roll over in bed. So the silk sheets we talked about. But also taking a nighttime dose of levodopa or Parkinson medicine can help that. Same thing with the tremors. Now, if people are having a lot of dyskinesia or wiggling during the night, lessening the nighttime dose of medicine may help that. And some people believe, and I've seen it happen, that if you're having a lot of dreaming, not that nightmare acting, but just very vivid dreaming, that a smaller amount of medicine at night may help. Now, if people are very anxious or depressed, that will cause problems with sleep. You know, if you're worried, you're going to be up all night worrying. And people with depression may not feel blue or sad or even be tearful, but they may wake up multiple times a night, wake up at 4 in the morning for no reason. So depression and anxiety are very common. It's a chemical imbalance we see in Parkinson's, not just the adjustment thing, but it's treatable with medications, and the sleep can improve if we treat the depression and anxiety. Dementia refers to memory loss. And sometimes just the dementia itself can cause people to have fragmented sleep and have a reversal of their day and night. So sometimes we have to use medication to normalize that. All right, now restless legs. This is a very common condition, and you've probably seen commercials or experienced it for yourself. Probably 10% of people walking down the street have this, and even more commonly in Parkinson's. And basically, it's a condition where every time you go down, lay down to relax, just when you just want to go to sleep, you get this crazy, uncomfortable, hard to describe sensation. Creepy crawly has been described, tingly, just an intense sensation, mainly in the legs, though it can affect other body parts, where you just have to get up and move. And people have to get up, walk around, sit in the recliner, do this and that, and then they go, okay, I'm tired now, I'm going to go back to bed. And then the itchy feeling comes back. It can be very unbearable. One thing I want people to know about this is that there are some medicines that can make this worse, and avoiding those things can help. So alcohol puts people to sleep, but it fragments your sleep and worsens restless legs. So having alcohol too close to bedtime can actually worsen the restless legs, even though it'll knock you out in the beginning. Benadryl is an over-the-counter allergy and sleep medicine. It has a lot of names, but diphenhydramine is the generic. And people think, oh, well, it's over-the-counter. It's not prescription. It's better for me. But actually, that's not necessarily true. Diphenhydramine is not good for people with memory problems because it can worsen that. It can cause constipation and dry mouth and worsen restless legs. So it's not right for everyone, even though it's over-the-counter and apparently safe. Sometimes prescription drugs may work better depending on what the sleep problem is. Dopamine blockers, I always harp on this because I'm always surprised how many people have been put on things like Abilify or Risperidol or Zyprexa. Now, these are antipsychotic medicines. There's also nausea medicines, Reglan, Compazine, and Phenergan. These are drugs that block dopamine. And we're trying so hard to increase your brain dopamine with levodopa. And then you go on these medicines that block dopamine. It can make the Parkinson's worse and make the restless legs worse, because the treatment for restless legs is also to stimulate the dopamine or increase the dopamine. So if you're on one of those medicines, you should review this with your doctor. Make sure you really need to be on that particular medicine. SSRI refers to serotonin, selective serotonin reuptake inhibitor, or certain antidepressants have been linked to increased leg movements and sleep, especially in men. So sometimes we'll move them to the morning or switch you over to another antidepressant if the restless legs are very bad. Other things people have tried, narcotics can work, but they're addictive. Melatonin is a pretty safe natural supplement that you can try. People who have low iron levels, giving high doses of iron, especially IV, can help. Certain vitamins have been beneficial. And I've had people tell me just things like putting the pillow between their legs, or wearing a certain pair of stockings, or soaking their legs in warm or cool water. So sometimes people find their own tricks. Neurontin is a pain medicine that we use to decrease tingling, and clonazepam is a sleep drug, which is useful for lots of different things. So there's lots of treatments for this. Just be sure to discuss it with your doctor. Now, leg cramps, this is a separate symptom and very, very hard to treat sometimes. This is when you get the Charlie horse in your calves, and just about everybody has had this at night. Sometimes it's caused by nerve problems. So if you have diabetes or neuropathy or some of these other medical problems, nerve problems can cause an increased irritability of the nerves and cause cramping. But sometimes it just happens from Parkinson's for no apparent reason. The first thing I try to find out is, are there dopamine drugs running low? So again, the nighttime levodopa can help this. But if not, then I'll first try non-pharmacologic things, so stretching or light exercise, not too close to bedtime. The warm bath or cool water can help. Some people swear by the potassium or the bananas, or drinking some water. Now, quinine used to work really well. It still does, but it was taken off the market because it caused irregular heart rhythms. You can still get some quinine in tonic water. The trouble is, if you drink enough tonic water to get a lot of quinine, you're peeing all night, and that defeats the purpose. But some people get some benefit from that. Sometimes I'll prescribe muscle relaxants or drugs like Klonopin if the sleep is very severe. Neurontin, which I talked about, is that pain medicine. Verapamil is a blood pressure pill that can relax muscle spasms sometimes. Vitamin E has been linked to a good effect, but not to exceed 400 units a day, because too much vitamin E is a bad thing for your heart. And very rarely, if really severe, I have injected Botox, which is a very powerful muscle relaxant, into the legs. REM behavior disorder, I think, is a very underdiagnosed condition, and I ask people about this every time they come in. Basically, in this condition, people move during their dreams, and they dream that they're being chased or attacked by somebody. And instead of being paralyzed in sleep and just the eyes moving, people will actually punch, scream, and kick, usually their bed partner. And you know that it's serious if the bed partner is sleeping in another room. That I sometimes will ask, "Oh, are you having any nightmares?" No, because the patient doesn't know all the time. They're sleeping. And the spouse will say, "I haven't heard anything," and then you find out they're upstairs. So the importance of this is, I've had a number of people not only wake up partially during the night, so fragment their sleep and be tired all the next day, but broken lamps and things from knocking things over at the bedside, kicking things. I've had several people fall out of bed. I've even had a couple people dream that they were jumping and actually jump into a headpost or off their bed and injure themselves severely. So, okay, I'm only having nightmares a couple times a week, but if it's a violent thing and it's happening frequently, it could be very serious for your health. The person is asleep and doesn't know they're doing it. And the other thing I hear from people is that, oh, well, such and such medication caused it. But actually, people can get this even before they're diagnosed with Parkinson's, and therefore before they're on any medicine at all. There's a lot of research going on to try to detect Parkinson's even before the person knows they have it. And one of the signs is REM behavior disorder. That, along with constipation and loss of smell, could possibly predict Parkinson's years before a tremor shows up. And then when we get a treatment that can slow down or reverse the disease, then we want to identify people sooner. So my point is, if you have the symptom, 2/3 of these folks later develop Parkinson's or something like it. And so it's a pretty serious symptom to pay attention to. And I think it affects at least half of people who have Parkinson's at some point or another, though it tends to come and go. People will have it for a few months, and then they won't have it for a couple years. If it's happening, and it's happening severely or frequently, I recommend you go on the sleeping drug Klonopin. Nobody wants to go on a sleep drug, but if it prevents you from launching out of bed or injuring your spouse, then it's a good thing. I used to have a video, but YouTube took it off, so I don't have it anymore, but basically shows a guy punching his pillow. So I'll try to act it. And this sleep study shows that there's abnormal muscle activity in the body during REM sleep when it shouldn't be happening. Okay, sleep apnea. OSA stands for obstructive sleep apnea. Apnea means stopping breathing. Obstruction means blockage. And basically what happens is that when people are sleeping, their muscles get really relaxed. Sometimes the airway will collapse, and then the air can't get into your lungs. And so what happens then is the patient will stop getting oxygen to their brain. The brain will say, I'm suffocating, and wake up. And then the airway will open. And every time that person tries to relax, the airway will collapse. And so they're waking up partially multiple times a night because the airflow to the brain is stopping. And even if a person is not aware that they're waking up, they're not ever reaching a deep stage of sleep because the air going into the lungs is repeatedly being cut off. Now, it's very common with people with large necks. You can imagine, because large necks will collapse and close the airway. But even in slender people with Parkinson's, it's extremely common. I often will say, you know, you're very sleepy and you don't have this, that, and the other. I'd like you to get a sleep apnea test. Well, I don't snore. Well, the absence of snoring doesn't rule out sleep apnea. There's something called hypopnea, which is a partial sleep apnea. Sometimes people just don't breathe quite enough to get enough air moving, and that could be a problem as well. And this is a very treatable condition. You can basically have surgery if there's a blockage, or wear a mask that pushes the air actively into your lungs. Weight loss to get a more slender neck, stopping alcohol. So alcohol, knocks you out and makes your airway more collapsed. Sometimes people only have sleep apnea when they're sleeping on their back. So, they get a shirt with a pocket and put a tennis ball in there so they can't roll onto their back, and sleeping on their side may help. Or just elevating the head of the bed. But the point is, to find out if you have it, you have to have the sleep study. And they can diagnose it, and they can recommend what you need to do to fix it. Once you get those deep stages of sleep, you'll have more energy, more mental focus, the memories will be consolidated better, you'll be less irritable and anxious, the mood will be better, the tremor will be better, everything will be better. And if you don't treat the sleep apnea, there is an increased risk of headaches, high blood pressure, obesity, heart attack, stroke, lots of things. And so some people don't want to know that they need to wear one of these masks. But wouldn't you want to do everything you can to be more energetic and have the best memory and mental focus? And these are just pictures. You can have a mask that's going in the nose, covering the whole face. If one mask doesn't work, I say try another one. I've had people who are mouth breathers. They need a chin strap. Or one of their masks leaks and they get dry eyes. Well, they get a better fitting mask. Or they feel like they're suffocating, and you get a machine that's programmed to have lower pressure when you exhale versus inhale. But you have to report why the mask is uncomfortable. And there are ways to fix most of these problems. So EDS refers to excess daytime somnolence. I have this 15% figure here, but I think it's a lot higher than that. I think a third or half of people I talk to are sleepy. We talked about a lot of the things that we do to try to identify sleep problems and fix them. But let's say we've ruled out sleep apnea, we don't have heartburn, et cetera, good sleep habits, but you're still sleepy. Then we look at the medications and what else can we do. So Sinemet is carbidopa-levodopa, and some people will take their levodopa and then sleep for 2 hours. Well, the regular carb-levo is probably the most effective, but it's most effective because it hits you hard. You know, hits you and then it's in your system for a couple of hours. If you use the controlled or slow-release Sinemet, it doesn't last any longer than the regular, but it hits you slower, which is good for some things, like if you get dizzy or sleepy or nauseous from your medicines. So sometimes I'll try switching to a different form of Sinemet. Dopamine agonists are your Mirapex and Requip, or the Nupro patch, if any of you are still on that. And dopamine agonists are great for controlling movements because they last longer, so you're not so up and down. But it causes a lot more drowsiness than levodopa. So if you're on a lot of Mirapex and a little bit of Sinemet and you're very, very drowsy, chances are you should be a little less dopamine agonist and a little more levodopa. If we've tweaked and adjusted your medicines and you're still very sleepy, sometimes you need a stimulant. And so a couple of these are Provigil, Nuvigil, which unfortunately it's hard to get the insurance companies to cover them, but they can help the mental focus and the alertness if we can get it covered. Oftentimes you need to have a sleep study to get the insurance to pay for them. Amphetamines, which are, uppers basically, they're like 20 cups of coffee. And they work really well, and they're generic, so they're cheap, but they're also a controlled substance because they're party drugs. And it's harder to maintain because you have to get a monthly prescription, and you have to bring it in person. You can't fax it over, but it can help. Some antidepressants can increase your energy as well. Sometimes we need to use a medicine to help you sleep better at night, what we call sleep consolidation. And what I choose really depends on what else is going on with the person. So if there's some depression or anxiety, I'll use a sedating antidepressant first because these aren't habit-forming. And they tend to be a bit lighter than just the regular tranquilizers. But Elavil or amitriptyline is one that's commonly used because it can calm overactive bladder and relieve some nerve pain along with helping the mood and sleep. But it can cause dizziness and constipation and weight gain, so it's got side effects too. Mirtazapine or Remeron is one of my favorites because I find it very effective for treating depression and anxiety. And it's very, very well tolerated, except it makes people sleepy, which is what you want. Probably the most unpleasant side effect of this is weight gain, which is good if you're very thin, but not good for most of us. But that's a side effect to be aware of. And trazodone is a very light antidepressant as well. Clonazepam or Klonopin I use for REM behavior disorder. It's the best medicine for that. It's also helpful for tremors, restless legs, and just muscle tension and anxiety. But it is a tranquilizer. It's very similar to Valium and Ativan and these drugs. They're habit-forming, and they make you groggy. And if you get up during the night to pee, you may be unsteady or groggy from it. These are some hypnotics. Basically, all they do is put you to sleep and help you stay asleep. They don't really treat any of the other symptoms. But sometimes that's all you want. Ambien, I'm sure many of you have heard of this one. It's been reported to cause sleepwalking and other bizarre behaviors, but it's very effective. It puts people to sleep. And if you have trouble maintaining sleep, there's the controlled release. And some of these Lunestas got very few side effects, so we'll use that if one of these didn't work. Melatonin I use quite a bit because it helps restless legs, and it helps people with sleep phase problems because there are always these night owls. They don't want to get up till noon, and they're up till 2 in the morning. It can help reset your sleep clock, especially with jet lag. And it's not habit-forming, and you can buy it over the counter. Rosarum is a prescription melatonin-like agent that it's also very safe. Sometimes I'll use Seroquel, which is actually an antipsychotic, and what that means is it's used to treat hallucinations. Some people with Parkinson's will see things that are not there sometimes, and that could be a side effect of the dopamine drugs that we give to improve movement. But even if there are no hallucinations, sometimes I'll use Seroquel because it's a powerful anti-anxiety drug. And if you've tried all this other stuff and it's not working, this is one antipsychotic that will not worsen the Parkinson's. And that's in direct contrast to typical antipsychotics like risperidol or Zyprexa or Abilify, which can worsen your Parkinson's symptoms. So once again, alcohol, you party now and get knocked out, and then 3 hours later you're bing, wide awake. And with restless legs. So, you know, a drink or two, okay, but 3 or 4 and then more and then right at bedtime is just going to fragment your sleep. I already talked about Benadryl, why that's not my favorite. And some of these drugs can cause increase in leg movements in sleep or fragment sleep or suppress REM sleep. So I'll use them if I think this is the main problem and they need to be on it, but it's something to be aware of if there are other sleep problems. So briefly, make sure you take the time in the office to tell your doctor if you're too sleepy or if you're having trouble sleeping, because this is a medical condition. You know, sleep is something very important for your medical health, your mood, your Parkinson's. And a lot of these things, if you just ask about them, you can find out what's going on and fix the problem. A lot of it is up to you to have good sleep habits, avoid behaviors or certain medicines that can worsen your sleep, but also to have that sleep study if you're one of these folks who are chronically overdrowsy, and be active during the day and get the best sleep at night. You know, I think everyone in this room is here because you're a take charge kind of person. You want to do everything you can to make your life better. And people don't realize that sleep is something you have to take charge of as well and pay attention to, and it can give you a lot of rewards. That's it.
Thank you, Dr. Rowe. Outstanding presentation. And I hope everybody has some good takeaways from that can help you get through every evening and make yourself better every day. I'd ask the remote sites, if you would now, to turn on your microphones so we can hear you when you ask questions. And as we always do, I'll call you by site. We had an excellent turnout today. There's 19 sites that have joined us, including Spokane, which makes 20. So please bear with me as we go from site to site to ask questions. So I'm going to mix it up a little bit so everybody has a chance. And let's start with Miles City, Montana. Anybody have any questions in Miles City? Okay. And you can always come back. Holler if you have a question. Let's go to OMAC, Mid-Valley. We're going to get one, I know. No, they just haven't opened their mic yet. Yeah. Again, if you guys could open up your mics so we can hear you, please. Thank you, OMAC. Let's go to Anchorage, Alaska. Providence Anchorage Medical Center. Did everybody fall asleep? No, I don't think so. Okay, nothing from Anchorage. Walla Walla. Providence.
Can you hear me?
Yes.
Can you hear me?
Yes, we can.
I have a question. My doctor has put me on Cinnamate every 2 hours. Now, during the night, I have to get up 2 or 3 times. Should I continue to take it during the night, too?
Well, it's hard for me to give medical advice without knowing or even seeing you, but Yeah, Sinemet, unfortunately, is a very short-acting drug, and a lot of people wake up during the night because their medicines have worn off, and that can cause trouble rolling over in bed, or tremors, or restless legs. So some people cannot tolerate dopamine agonists due to the side effects that they can have, or have tried other sleep drugs and they haven't worked. And so it may be that the only solution is to take Sinemet during the night, but you know, it really depends on the individual situation. But there are people who do have to wake up in order to take medicines.
Do any of you have any questions? Well, thank you very much
All right,
for a good
you.
presentation.
Thank you very much. Let's Kirkland Evergreen Healthcare, please. Okay. How about Billings, Montana? Billings, Deacon.
Yeah.
Dial 0, tell them to bring some batteries down to us.
I have a request from Billings.
Yes.
Do you hear? Would you ask the young lady not to stand behind that piece of equipment so we can see her? Thank you.
We have another question. How strong or how many milligrams of melatonin is it safe to take?
That's a good question. I generally am pretty conservative. I've had people get benefit from 1 or 2 milligrams, though I find people need about 5 or 6. I've actually had people come to me on 10 milligrams a day, which I haven't prescribed myself, but people seem to do fine with it. So I have not had any adverse effects from the melatonin, though you do read that there are potential interactions with the heart and things. I haven't had any problems, but I try to keep it around 3 to 6 milligrams normally.
We have another question. Joe?
I'm on 95% pure oxygen.
battery.
On 95% pure oxygen at night. I just wonder if the rebuilding process of the body that takes so many hours to rebuild at night is speeded up because of the high oxygen content.
That's a very good question. I don't know the answer to that, except that most people don't need supplemental oxygen if there's normal lungs and good airflow. So I don't believe there's evidence that hyperbaric oxygen or more oxygen than a person needs will speed up the recovery. I think it's mainly for people who are unable to get enough oxygen that they need to be on oxygen just to keep up with normal amounts of airflow.
Yeah, I found that I don't really need over about 4 hours of sleep. I wake up after 4 hours and I'm ready to go again.
Well, you know, 4 hours of good quality sleep is worth more than 8 hours of bad sleep. So I've had people tell me that once they got their oxygen or their CPAP or whatever it is, even though they're not sleeping more hours, that they feel more energetic. And I think that has to do with the quality of the sleep.
Thank you.
Welcome.
Thank you for the presentation.
Welcome.
All right, thank you. Let's go to Virginia Mason Medical Center in Seattle. Any questions? Okay, how about Bonner General in Sandpoint, Idaho? Okay. Samaritan Healthcare in Moses Lake. Any questions?
No, I don't think so. Thank you.
Okay, thank you. Tri-State Memorial Hospital in Clarkston.
Yes, hi, thank you. We have 3 or 4 questions. Dr. Rowe, if a patient's sleep is interrupted for a bathroom visit 3 or 4 times a night, is it possible to get back to non-REM sleep and get enough of that non-REM sleep?
Yes, I think so. If you're able to go back to sleep, and I showed those sleep cycles, they're about 90 minutes. So if you're able to get a solid 90 minutes in between, theoretically you could, and you're able to go right back to sleep. I think the trouble is when something wakes people up, and a lot of folks with Parkinson's are light sleepers, and then you're awake. And 2 hours later, you're still awake. I think that's the biggest concern with anything that will disrupt the sleep. Of course, if you stay asleep, that's better. But sometimes it's very hard to treat the overactive bladder at night due to the side effects of some of the treatments. So I think a good indicator of how well you're doing is that sleepiness scale. If you're not excessively sleepy, then you're probably getting enough rest.
Okay, thank you. I have 2 more questions.
Sure.
You mentioned Zyprexa and said it can worsen PD symptoms. Does it help appetite and fatigue? Does it improve those things?
Well, Zyprexa is an antipsychotic, so it blocks dopamine, and it does have a potential use in select Parkinson patients, especially people with what we call psychosis. That's when you have very active hallucinations or paranoia or agitation. Usually we first try to cut down the Parkinson medicine, but then sometimes people can't move, and so we need to put on something to block that agitated behavior. And usually we'll try Seroquel, but if that doesn't work, then what? And Zyprexa should only be reserved for those cases where we've already tried cutting down the Parkinson medicine, especially the dopamine agonists and the amantadine and things like that. And we've already tried Seroquel, and that didn't work. We've already tried the memory medications, and that didn't work. So all this is just to say there are very few indications, but they do exist when Zyprexa is useful. It does promote weight gain. So if someone's very, very frail, it can stimulate the appetite. It does put people to sleep who have severe anxiety, so it can help with that. But it does have the risk, very real risk, of increasing tremors and stiffness, increasing falls in the elderly, and sometimes the effects can last for months after you actually stop the drug, like Haldol especially, but Zyprexa is one of them as well. Sometimes people who take Zyprexa or Haldol or those drugs chronically can develop other involuntary movements, what we call tardive dyskinesia. These are wiggling movements of the mouth or truncal movements or neck twisting. And so people who are on Zyprexa really, I would just make sure that everything else has been tried first, because it's got a lot more side effects in Parkinson patients.
Thank you. Last question, Dr. Rowe. You mentioned stockings, and I'm thinking of compression stockings and TED hose. 2-part question. You mentioned stockings in relation to improving restless leg syndrome. Are you talking about compression stockings to be worn at night?
Well, in this case, I've started to collect, and maybe some of you can share what's worked for your restless legs. I had a lady who had a pair of regular stockings. They weren't compression stockings. She just found that wearing the stockings, just the light touch of something on her leg, helped. And people have told me a certain pair of socks. I think compression stockings can be helpful, but in that particular case, I was just saying people try different things. Sometimes just having something touch the leg can be good or bad for that.
Okay, and on the compression stockings, thinking of the daytime we use now, could they be worn every day?
They can.
TED hose?
Yes, and so I often will use these in folks who have dizziness or low blood pressure when they stand up. Having tight hose on can return some of the fluid from your legs into your circulation and raise the blood pressure. And so it's most helpful for people who are feeling faint or lightheaded or have a lot of ankle swelling. But yes, it can be worn. Obviously, you do want to, make sure the skin is clean and no wounds or anything underneath there. But yes, they can be worn daily.
Okay, thank you very much.
Thank you for your questions. Let's go to Ritzville, East Adams. Okay, moving right along. Kootenai Medical Center, our friends in Coeur d'Alene.
Oh, we're here. We have 2 questions.
Where I talk.
You're just talking to that, I think.
Yeah.
Hello, I have a question about the Lunesta.
Yes?
I have a question about the Lunesta. I can't sleep at all at night, so my doctor prescribed Lunesta. I thought you said something about it could make the symptoms worse. Is that correct?
No, I think Lunesta has actually got very few side effects. It's a pure hypnotic, so it basically all it does is put you to sleep. So I actually use it and haven't had a lot of problems with it. It's the dopamine blocking drugs you have to be careful about worsening the Parkinson's.
Thank you.
I have a question that's similar. My doctor has me on Ambien, and I wondered, is there any limitation on how long or how often you should take this? It seems to work all right, but I'm hesitant to use it every night.
That's a very good question. Normally, we don't like people to take sleep medicines chronically, and they typically say that the sleep drug should be used only for acute insomnia or as short as 2 weeks. That's different from Parkinson's. I think with Parkinson's, you have chronic sleep problems, and I actually think it's better to take something and sleep through the night than not sleep and have the consequences of that. So I quite commonly will use a sleep drug like Ambien for 6 months at a time, and then reassess how is the sleep going, and maybe try to come off of it. But if you need it chronically, I do use long-term sleep drugs for Parkinson's.
And you say come off of it. Is it addictive?
So any sleep drug can be potentially habit-forming, with the exception of the melatonin and rosarum. Even the antidepressants are not technically habit-forming, but they have to be weaned off. So yes, you can get used to sleep drugs, and what that means is it may be difficult to come off the drugs once you've been on them for a long, long time. But it's possible. Some people can. Most of the sleep drugs don't have another feature of addiction called tolerance or craving behavior. So if you take one Ambien, very rarely do people come back and say they need 2 and 3 like they need narcotics. So I've had people on the same tiny low doses of sleep drugs for years, and it's never escalated. Sometimes, especially with the benzodiazepines or narcotics, people do get used to it and then may need a higher dose over time. If that's the case, I try to gently wean them off and find something else to take with it or instead of it, if I can. But most of the hypnotics aren't addictive in that sense, but they are habit-forming in the sense that they're hard to come off of if you've been on them a long time. I hope I didn't dance around the topic too much.
Okay,
Thank you.
Thank you. Okay, let's go to Providence Mount Carmel Hospital in Colville. Any questions?
Hi, we don't have any questions, but we did want to let you know that our numbers grew. This is our 2nd month, and we grew from 3 to 8, so we're really happy to be part of this program.
That's outstanding. Thank you for joining us. We appreciate it. Okay, let's go to Pullman Regional Hospital.
This was out there when this to be before I came here.
Any Cougars out there want to ask a question?
We have a question.
Okay, go ahead.
Okay. I got in late at the beginning of this presentation, and I'm just wondering if you do that sleep study yourself.
I don't do sleep study. Sleep is actually a specialty, just like movement disorders is a specialty, and requires fellowship training. A sleep doctor can be a neurologist, but it can also be a pulmonologist or a psychiatrist. So I will generally refer people to a sleep specialist, and they'll meet you and talk to you and examine you just like a regular consult, and then they will interpret the sleep study.
Are you taking new patients?
Are you still taking new patients?
Absolutely.
Thank you.
Thank you.
All right, thank you very much. Okay, let's go to, where are we here? Syringa General Hospital in Grangeville, Idaho. Okay. How about Dayton General Hospital?
Yes, we enjoyed the program. We have no questions.
Okay, thank you for joining us. Jefferson Healthcare in Port Townsend. Any questions, folks?
Townsend has no questions.
Okay, thank you for joining us. Last couple, Kennewick General Hospital. All right. And last but not least, our friends in Pendleton, Oregon. Any questions?
We have one question in regard to Cinemet substitute. My husband suffers from almost chronic dizziness, and I didn't hear about any Cinemet substitutes. Offer any?
Cinemet substitutes for what symptom?
Dizziness. He has a lot of dizziness, and I thought you said a Cinemet substitute may help relieve dizziness.
Oh, I don't recall saying that, but dizziness, do you mean feeling lightheaded or faint or off balance? Or neither?
Could you repeat that, please?
By dizziness, do you mean feeling lightheaded or faint? Or is it just a balance issue? Or is it the room spinning all around? Vertigo?
I'm not getting any response from my husband about that. He just says dizzy, so I can't clarify.
Well, all the drugs for Parkinson's that help dopamine can cause low blood pressure or dizziness. Cinemet is actually the best one. Mirapex and Requip and dopamine agonists cause much more of a blood pressure drop when compared to Cinemet. I think you may be referring to the difference between controlled or slow release Cinemet and the regular immediate acting Cinemet. The regular Cinemet acts quicker and more reliably and is 30% more potent, but it's also 30% more potent, so it hits you more with the drop in the blood pressure and the drowsiness and the nausea. So if you're someone who has a lot of side effects, I'll sometimes try the weaker, less effective, slow-acting Cinemet because the side effects are less. But they're both the same drug. They're just different formulations that release slower versus quicker.
Okay, thank you.
This isn't a question, it's just something to let all your listeners know. I just got back from the Seattle to Portland bicycle ride, and we had 73 two-day riders, and we had 11 one-day riders, and they reached their goal of $100,000 for Parkinson's.
Excellent. I did that 2 years in a row, so that's a great, great cause.
And then there's some of us that are going to walk the Portland Marathon.
Oh, good for you.
Okay, this is Kirkland. This is Evergreen. Can you hear me?
Yes, please go ahead.
That was, this is Alicia. I'm the program director for Northwest Parkinson's Foundation, and I'd like to add what Jackie was saying about the STP this weekend. Northwest Parkinson's Foundation, we did have actually 73 riders, and 5 of our cyclists were people that were challenged with Parkinson's. And that was Northwest Parkinson's Foundation. So, and Suzie, how are you?
Oh, good, Alicia. How are you doing?
I'm doing great. Are you talking
good.
to me?
You get one off. No,
but it went very well.
Well, that's outstanding. And thank you for being there with us. I'd like to again thank all the remote sites for joining us and for all their questions. So
this is Mount Carmel. Could we break in? I'm sorry, we do have a question.
Go ahead.
I'm sorry. One of our participants asked about short-term memory. In the middle of a thought, we'll lose that thought. Could that be attributed to bad sleep?
That's a very good question. That's a common symptom of Parkinson's, and it could be just from the Parkinson's. But even someone with very good memory otherwise, if the sleep is not good, it could cause that exact same symptom. So could uncontrolled depression. And so all three of those things can cause that exact symptom. And so we'll probably try to rule out all the other possibilities. You know, it could be the memory, could be the sleep, or it could be the mood. And so sometimes we just have to try to treat one or the other and see what makes it better.
Thank you.
Okay, so let's move to our Spokane audience now. Caitlin has a microphone. If you could wait for her, she'll bring it over to you. And then please ask your question.
My question is about the dreams, the animated dreams. So is that a side effect from the carbidopa levodopa, or is that a Parkinson? Because he's very animated.
Mm-hmm. So there's a couple of different types of things. There's what we call vivid dreaming, and where you just have technicolor dreams. They're so real and vivid. And I often hear that as a side effect of medication. Often they start medicine, either dopamine agonist or Sinemet, and they come back, wow, I'm having these crazy dreams. But the other thing, the REM behavior disorder, which is when you're having the nightmares of being chased or attacked and you flail and scream, that can happen years before Parkinson's is diagnosed. It can happen on no Parkinson medicine whatsoever. It can happen out of the blue on someone on stable medications. So it's very hard to know exactly what the relationship is between medicines and REM behavior disorder. But there are sure a number of studies that have linked certain medicines like dopamine drugs or antidepressants or other things to increase risk of REM behavior disorder. I find it hard to make that correlation sometimes, and sometimes we can't really get rid of the Sinemet because it's helping, and so we'll use the clonazepam to help suppress those episodes.
And is that a daily treatment, or is that?
I'll usually use it daily while the REM behavior disorder is active. So if you're having it 2 times a week or more, I'll usually say go on this every night for a couple of months or a few months. And then if you haven't had any in a while, we'll try to come off of it and see what happens. Mm-hmm.
I was diagnosed about 13 years ago. And since then, I've had 4 surgeries where I was put to sleep with general anesthetic. And after each time of having general anesthetic sleep, I got worse. And especially after the first major surgery, I had extreme anxiety, which I did not experience before. How is this related?
That's a really difficult question because there are many different medications used for anesthesia, and there are certainly reports of potential interactions with other medicines with the anesthetics. There's also the question of the surgical procedure itself. It's a tremendous stress on the body, and that sometimes can cause an increase in Parkinson's symptoms. Just the stress that the body goes through surgery, not to mention the anesthesia. I'm not sure I can really accurately answer that question, only that it has the stress of the surgery and or the medications have been linked to increase in symptoms. But most of the anesthetics are very short-acting drugs, so it can't be explained on that alone.
Parkinson's support group.
Well, enjoy the rest of your free afternoon.
I will, thank you.
Hope the air conditioner doesn't come back on.
Well, yeah, tomorrow I'll go back to work and find out.
I had a question. What do you think of valerian as a sleep aid? Is it up there with some of the others, or what?
I confess I don't know very much about valerian. I haven't had any problems with it, but I haven't prescribed it, so I haven't exactly followed people who are doing it. So I'm not sure I can answer that question very well. Seems well tolerated, but that's about all I know.
Is it effective?
I don't know because I haven't specifically recommended it and then asked people later, oh, did it work for you? So I don't know too much about it. Yes.
Are the sleep studies covered by Medicare?
To my knowledge, they are. I haven't had a single person on Medicare tell me they couldn't. Medicaid may be a bit trickier because most centers will not accept that. But even people on DSHS, I've been able to arrange sleep studies for them. They may have to travel a bit further, but Medicare has not been a problem.
And are they done in the Spokane area?
Yes. I'll take that back to, I don't know about Alaska. I think there may be in Alaska, I don't know if the centers there take Medicare, but most of the folks I see are Medicare, and I've had no troubles with them getting sleep studies.
Hi, this isn't exactly a question. It concerns restless leg. And I don't have medical training and no scientific study, but it's my opinion that a slight sexual stimulation can alleviate restless leg.
Good for you.
Any other questions, Spokane? Oh, there we go. I'm sorry.
I've been
No comment.
to come up that I felt that I could ask a question that might relate, but my question is such a foolish one, I'll just ask it anyway. Because I find when I get very, very tired, which I do often every day, and sometimes a series of days, get very tired. I missed my grandson's first birthday because I couldn't get away from the bed. And I find that sitting in a chair or sitting in a comfortable chair, sitting in other whatever's available, does not relieve the tired feeling. It takes the tiredness out of my feet and legs. Maybe sitting does, but to really get relief from the tired that I have in relationship to Parkinson's, that tired, to get relief that I need to lie down. Is that relevant at all? I've just discovered that for me to be really rested, I have to lie down.
Lie down awake or lie down sleep? You mean sleep?
I usually fall asleep, but if I'm not in a place where I can go ahead and fall asleep, if people are waiting or something, I just need to lie down for 10 minutes. Give me relief.
That's interesting. I don't know how to explain that other than, if you're awake and lying down versus awake and sitting, but certainly being recumbent is a very comfortable position to be, and more conducive to sleep than being in a chair. But maybe it's something about lying down. I don't know specifically.
Yoga might have some ideas about this.
If yoga might have. Oh.
What was that question again?
She doesn't do yoga, but would that help?
Oh, would yoga help? Thank you.
Would yoga help the tired feeling? Well, it's certainly worth trying. I think yoga does a lot of good things, not just exercise, but also calming the mind and the body. I can't answer whether it would work for you. I think you'd have to try it. Everybody's very individual.
Anyway, I suggest anyone who wants to try a new position for rest and rejuvenating themselves, just get lying down.
Any other questions, folks? Okay, well, Dr. Rowe, thank you so much. That was a fantastic presentation. Again, I'd like to thank our partners, Northwest Parkinsons over in Seattle, for their support, and certainly our sponsors and all our remote sites for being here today. Next telehealth is Monday, August the 8th, second Monday, same time. The speaker will be Dr. Lynn Kohlmeyer. She's a local endocrinologist that also specializes in bone disease, and so the subject matter will be Parkinson's and bones. And as always, the DVD will be available by contacting the PRC at our phone number, or go to our website at www.spokaneparkinsons.org. So again, thank you for being here today. And, oh, is this for her? Yeah. And don't forget Parky, right? Parky's our mascot, and that's for you. Anyway, thank you, everybody. I appreciate you being here, and I hope you got some good out of it. Kohlmeyer. And she's here in Spokane. And everybody drive safely. Have a great day. Thank you.